Good afternoon. I'm Catherine Santoro, Director of Policy and Development at the National Institute for Healthcare Management Foundation. And on behalf of NIHCM and AMCHIP, welcome to our webinar today. By 2020, the U.S. could have 8,800 fewer OBGYNs than we need, and in much of rural America, women already encounter barriers when trying to access prenatal care. With many rural hospitals closing their obstetric units, it's also becoming more difficult for many women to deliver their babies at a nearby hospital. AMCHIP and NIHCM are pleased to have an excellent panel of experts with us today to explore ways to ensure nationwide access to maternity care providers. Before we hear from our speakers, I'd like to quickly thank NIHCM's President and CEO, Nancy Chalkley, and the NIHCM staff who helped to convene this event today. I'd also like to thank our partner in convening this event, the Association of Maternal and Child Health Programs, and thank them and also introduce Emily Eckert from AMCHIP to make brief introductory remarks.
Thank you, Catherine, and welcome to all of today's webinar participants. As mentioned, my name is Emily Eckert, and I'm a Health Systems Transformation Analyst at the Association of Maternal and Child Health Programs, or AMCHIP, in Washington, D.C. AMCHIP represents Title V maternal and child health programs within state public health departments. Our members include directors of maternal and child health programs, directors of programs for children with special health care needs, and other public health leaders who work with and support state MCH programs. We advance our mission of protecting and promoting the optimal health of women, children, and families by disseminating best practices in MCH, providing educational opportunities like this webinar to state MCH professionals, and advocating on behalf of our members and the populations they serve. Ensuring access to quality maternity care is a priority for AMCHIP's members, many of whom are in states with significant health provider shortage areas. Today's webinar will explore solutions and challenges to addressing the nation's growing maternity care workforce shortage. We are thrilled with the overwhelming response to today's event, and we look forward to future collaboration opportunities with provider groups, health plans, public health agencies, and others to improve access to maternity care for all women in this country. And with that, I'll turn it back over to Catherine.
Thanks, Emily. For our audience, you can also find biographical information for all of the speakers along with today's agenda and copies of slides on our website. We also invite you to live tweet during the webinar today using the hashtag MCHWorkforce. I am now pleased to kick off our event and introduce our first speaker, Lisa Kane Lowe. Dr. Lowe is an Associate Professor and Associate Dean for Practice and Professional Graduate Studies in the Department of Health Behavior and Biological Sciences at the University of Michigan School of Nursing. She's also the current president of the American College of Nurse-Midwives. We're so honored she's with us today to discuss maternity workforce challenges and how we can support midwives. Dr. Lowe?
Thank you. And as we move into the next slide, it's my pleasure to be a part of this really incredible panel to be able to bring awareness and thoughtful consideration to where we might go in moving forward in addressing the maternity care provider shortage in this country. As we start the panel off, I've been asked to just provide some background, and so in an effort to do that, I'm going to just offer some context for how we're looking at the concerns and the gravity of it. As we look at the number of women who will be needing services, in essence what this slide is telling you is that there's a growing number of women of childbearing age who will need care over the next several decades, and that as we're seeing that growing need, when we map that against what our current provider availability is, what we see is that ACOG, the American College of Obstetricians and Gynecologists, when they look at where their physicians are located, we can see that almost 46% of the counties in this country don't have access to an OBGYN physician provider. And at the same time, we have some maldistribution in where the providers are. In addition to looking at the role of obstetricians and gynecologists, we can also compare that to availability of another part of the maternity care workforce, certified nurse midwives and certified midwives, which are represented by the American College of Nurse Midwives. And using the same approach to looking at where we have midwives in this country as certified nurse midwives and certified midwives, we have some of the same challenges with the distribution and availability of them, with almost 56% of the counties in this country having no access to a certified nurse midwife or certified midwife. And when you map those together, what we see is that we have a number of areas, particularly rural counties, that don't have access to members of the maternity care team in the form of a midwife or certified nurse midwife, certified midwife, or an OBGYN physician. And that we also have continuing challenges with the distribution, where high density in some areas and then zero access in others. In addition, the other member of the maternity care team, family physicians, what we're seeing with the family physicians is that they're having less of a role in the total number of individuals they attend during birth. And as they decrease in their presence, they're not only decreasing in total number in terms of the types of settings they're in with high volume deliveries compared to low volume, but the total number of family physicians participating in OB care has also decreased. So combined, we've got a smaller total workforce providing maternity care. And when we map that against the number of individuals in our pipeline and look in particular at first-year OBGYN residents and new certified midwives or certified nurse midwives, what we see in the distribution is that the number of OBGYN residencies is relatively static despite the growing demand and the concerns about distribution. And the growth in nurse midwives and certified midwives, while it's been slightly increasing, in total they represent about half the workforce that graduates each year to provide women's health care services. So in total, when we put all of these pieces together, what we see is that we have a static number of graduates by and large in OBGYN, and my colleague from ACOG will also be speaking to you more about the distribution of those providers, but a number of them go into subspecializations, and the number of midwives are increasing, but still at a smaller rate than the workforce demands would suggest are needed. We're seeing some changes in our provider demographics that are leading to different durations of time in practice at the same time that we're seeing this increasing need. So taken in total, as was provided by the introductory remarks, we're facing a significant and substantial shortage in the number of skilled providers who are able to meet women's health care needs for maternity care services. Now, just to offer a little bit of background on who I'm speaking to today in terms of the role of midwives as represented by the American College of Nurse Midwives, certified nurse midwives are individuals who are educated in the two disciplines of midwifery and nursing, and they're graduate prepared and complete a national certification exam offered by the American Midwifery Certification Board. They become then a certified nurse midwife with those two disciplines. In addition, taking the same national certification exam are certified midwives who are educated in the discipline of midwifery and earn their health credentials through their graduate degree as well and become certified midwives. Taken together, that workforce represents just under about 12,000 certified nurse midwives and certified midwives in the United States. Certified nurse midwives are licensed to practice in all 50 states. Certified midwives are licensed in only 5 states with a growing emphasis on encouraging access to licensure. An additional member of the maternity care workforce are certified professional midwives, and they're represented by the National Association of Certified Professional Midwives. So I'm not going to be speaking to them in terms of the role in the workforce specifically today, but they represent midwives who are licensed in now 28 states, and they provide care primarily in the setting of the home or birth center. Some states may also license midwives who are not represented by one of those three credentials, but who have state-based licensure. So there's some people refer to it as a lot of alphabet soup, but the key point that I want you to take away from this is just that there's variation in who's able to contribute and in what states to the maternity care shortage issues and development of an expanding workforce. What we do know about the role of midwives, though, is that a number of national and global studies have been done to look at what the contribution could be if you have access to educated and licensed midwives. And essentially, what is the takeaway from this slide is to put an emphasis on the fact that we can provide as midwives a significant amount of the care needed for women and newborns, and yet our distribution is the flip of a triangle when you look at a number of available midwives for contribution to the workforce compared to OBGYN physicians. And so thinking about the ways in which we provide our model of care and work together is something that I'll discuss a little bit further as we go on. What's important to think about in terms of the role of midwives is what their scope of practice and role is. And midwives who are certified by the American Midwifery Certification Board as CNMs or CMs provide the full range of primary health care services for women from adolescence beyond menopause. And these services include primary care, gynecologic, and family planning services, in addition to the maternity care support, as well as treatment and care of newborns through the first 28 days of life. So the scope of practice that midwives who are CNMs and CMs are educated to provide extends this full range of services and represents what is a significant amount of what many women will need in their lifetime. When we look at how to provide that care, one of the things that we want to think about is getting the right care at the right time in the right place by the right providers. And there's a different way that we can think about accomplishing that when we look at our workforce. Midwife-led care can really be independently provided care to individuals who are healthy or sometimes referred to as lower risk. Individuals who might have certain health conditions that require different levels of specialization may be provided care in a model that's jointly led by physicians and midwives, where consultation and collaboration is a part of the role. And then there's other individuals who clearly will benefit from physician-led care because of the specialized services they may require or the unique needs that they have. But taken in total, the opportunity to provide interprofessional collaboration is really an ideal model that could contribute to expanded scope of resources in our workforce. But when we want to provide this care, one of the things that becomes a significant challenge is the laws and regulations that may affect access to maternity care. And in particular, our laws related to scope of practice. And in each state, there's variation in what midwives are licensed to be able to provide and the ways in which they need to provide that care. The goal for ACNM in supporting midwives in their practice environment is to have what is referred to as full practice authority. And that's basically letting midwives who are CNMs and CMs be able to practice to the full extent of their education and training, with independent licensure that doesn't require supervision or legislate collaborative agreements, be part of the necessary contingency for them to be able to practice. And this approach to the practice model is in alignment with the joint statement of practice relationships between obstetrician gynecologists and certified nurse midwives and certified midwives as approved by our both of our boards. And that's that we're independent providers who are working together in a seamless, collaborative context in order to provide the services that individuals who seek our care need. And when we look at the way that full practice authority looks across the country, interestingly, what you see is a wide distribution where we currently have now, as of this summer, 28 states that allow for independent practice of certified nurse midwives and certified midwives, and then a number of others that require collaborative agreements either for prescribing ability or for the ability to practice. And some states that are considered the most restrictive require supervision, all of which prevent ready access to midwives as care providers and are linked to other distributions of where you have access to reimbursement for those services that you can provide. When we compare the state practice review to the number and density of where midwives are practicing, we start to see patterns where you have the highest distribution of midwives in areas where they have full practice authority and can fully provide care and services consistent with their education, and less distribution in states that have more challenging or restrictive requirements or barriers to practice. Often the concern when we look at scope of practice and distribution of providers is that somehow the linkage between scope of practice and supervision will tie into health outcomes. And one of our colleagues on this panel has actually conducted some important work that looked at the question of what happens when you have scope of practice laws that support autonomous midwifery practice. And what we learn is that when you have autonomous midwifery practice in states, you actually have more births attended by midwives in those states compared to states with more restrictive agreements. And you also see that in the more autonomous areas, having midwives be a part of the larger workforce to provide care and services also is correlated with improved health outcomes focused on reduction of cesarean section, improvements in preterm birth rates, and in low birth weight. So that we see a tie-in when you can practice to the full scope of your training and education with supporting improved access to a maternity care workforce that also contributes to improved health outcomes. So state practice laws become a primary focus for how we could improve our workforce and access to midwives in particular as members of the maternity care team. We also know that the way that we educate and train midwives and physicians could be further expanded to support more collaborative work in our educational settings. And we currently have a pilot project which is funded by the Macy Foundation with ACNM and ACOG to work together to develop collaborative practice opportunities for the curriculum of our residents and midwifery students. In this project, we have 4 demonstration sites, and the interesting piece of this is that not only are we trying to do the direct care changes in how we do the education, but we're also changing the accreditation requirements by engaging all of the agencies that work on accreditation of education programs so that they recognize the joint way that we're collaborating to do this work. So we see this as a real opportunity to expand the workforce as we expand the number of sites where we can practice together, providing the right care at the right time with the right provider. Other areas that we see as opportunities to develop expanded workforce is to really target rural settings with educational training. And we have a number of examples in the education programs for nurse midwives that focus on rural needs. One exemplar is Frontier Nursing University that currently enrolls about 50% of the students who are graduates each year, and they have specific curricula that support access to and providing services in rural settings. So more opportunity to scale up these types of model programs is something that we think will be really useful. And then a couple other highlights of areas where we think we have opportunity to expand the workforce include using, similar to having graduate medical education models where the training site is in the hospital setting and there's reimbursement and support for those services, the same can be applied to nurse education. And there has been a demonstration project that's looked at doing this, but only with 4 small hospitals. So we hope that this will be something that has good results and that could, again, also be scaled up in the same ways in which graduate medical education is done. Another opportunity is to look at who's available to train and support growth in our number of students, which requires having more preceptors who are available to train our students in the clinical setting. And there's an interesting opportunity in Georgia where they are providing education and precepting and giving tax deductions as an exchange of service and recognition of the contribution that these individuals who are precepting are making to the education of those who are providing maternity care in the future. And then another final example is that as we look at the ways that we are supporting training and education, we have to encourage more collaborative models, which includes the IPE training that I just highlighted from the Macy Foundation, but it also includes the ways in which midwives are engaged in supporting the training and education of our physician colleagues as they're learning to do lower-risk, healthy maternity care. And currently, we are advocates for legislation that would provide coverage for when midwives provide education and oversight under the GME model for residents in their training programs. And so these are just a few examples that we can think will be ways to really expand the numbers of individuals coming through the pipeline. And at the end, I would offer that as being someone from the University of Michigan with several degrees, I often think of the team as a critical quote in how I want to approach challenges and problems. And when I think about addressing the maternity care workforce shortage, collaboration is the theme, and I think you'll hear more exemplars of that as the rest of the individuals on this panel move forward in their presentations. So I thank you for your time and look forward to any questions that we have as we move through the process.
Thank you so much, Dr. Lowe. We're also so honored to have the American Congress of Obstetricians and Gynecologists with us today to share their perspective, and we're joined now by Mallory Schwarz, Federal Affairs Manager, to hear more about OBGYN workforce challenges and policy solutions. Mallory?
Thank you so much. Again, my name is Mallory Schwarz, and I am a member of the Federal Affairs team here at the American Congress of OBGYNs, or ACOG. Let my slides get up here. Great. Thanks again to AMCHIP and NIHCM for all of their work in arranging this webinar and a great lineup of speakers. I definitely agree with what Dr. Lowe said, collaboration. Today I'm going to address the OBGYN physician workforce and maternity care shortages with a specific focus on state and federal policy solutions. ACOG is the nation's leading group of physicians providing health care for women with more than 58,000 members. ACOG strongly advocates for quality health care for women, maintains the highest standards of clinical practice and continuing education of its members, promotes patient education, and increases awareness among its members and the public of the changing issues facing women's health care. These 58,000 members represent about 95% of all OBGYNs in the U.S. Health professional shortages threaten women's ability to access timely maternity care, which can have a devastating effect for women and their families. Every year, 1 million babies are born to mothers who did not receive adequate prenatal care. Without this prenatal care, babies are 3 times more likely to be low birth weight and 5 times more likely to die. This is devastating, but it's also costly for families as well as state and federal government. The average cost of medical care for a premature or low birth weight baby is $49,000 versus the cost of newborns without complications, which is only $4,500. Nearly half of women of reproductive age, which is 15 to 44, consider their OBGYN to be their regular physician. Yet there are major pockets of the U.S. where women do not have this access to needed OBGYN care. 49% of counties lack a single OBGYN. As you can see, these are in most states, but especially in the Midwest, the South, and the Mountain West. 9.5 million women live in these counties. Significant health disparities exist between rural and urban women. Rural women have less access to health care than urban women and experience poorer health outcomes. The ratio of OBGYNs per 10,000 women is highest in metropolitan areas and decreases in less populated and rural counties. In some rural areas, family physicians provide 100% of obstetric care. That said, practice data does show that obstetric services provided by family physicians, as Dr. Lowe mentioned, is decreasing, and now only 19.2% provide routine deliveries. Access to specialty women's care, like vaginal birth after a C-section or VBAC, and abortion are also a significant concern. Right now, 87% of U.S. counties had no abortion. In 2008, 87% of U.S. counties had no abortion provider, and 35% of reproductive age women lived in these counties. To be sure, OBGYN shortages vary across urban areas as well. Metropolitan areas with older OBGYNs and higher workloads are at greater risk of these shortages. This map shows drive times to hospitals with maternity centers. Drive times to maternity centers vary across the U.S., with the longest drive times, again, in the West. Around the country, more than half of women in rural communities live over 30 minutes away from a hospital that offers perinatal services and appropriate care. Changes in the OBGYN workforce have broad implications on healthcare delivery for women. Dr. Lowe touched on a little bit of this in her presentation. ACOG projects an OBGYN shortage of 18% by 2030. In these next few slides, I'll highlight some trends and challenges facing the OBGYN workforce. This is by no means an exhaustive list, but I'll try to hit the main points. There's a decreased number of residency graduates relative to the population of women. In 2016, the number of ACOG fellows per 10,000 women of reproductive age was 5.5, which is down from 6.2 in 2008. Meanwhile, the female population is expected to increase 36% by 2050. Concerns about physician shortages in the 1960s first resulted in changes to graduate medical education funding through the passage of Medicare and Medicaid. However, as Dr. Lowe's slides indicated as well, medical school enrollment has only increased minimally over the past 30 years. An increase in the number of residency slots in obstetrics and gynecology funded by Medicare would help accommodate the additional graduates and the increase in women seeking care. But we need increased federal funding to ensure that there's sufficient residency positions to meet the growing demand. Physician practice patterns are also changing. The physician workforce is aging, and the average number of work hours is declining compared to historic levels, with a large number of OBGYNs now nearing retirement. Younger physicians are more interested in work flexibility and meeting personal family obligations. Physicians under 35 report a desire to work fewer hours. Also, more physicians are employed than in the past. Only 53% currently own their own practices, compared to over 60% in 2008, just about 10 years ago. There's also been a significant change in the gender distribution of OBGYNs. Women represent nearly one-half of all students entering med school and residency, but for OBGYN, the 2016 residency class was 83% female. Female OBGYNs are more likely to keep part-time schedules in order to balance career and family needs. However, something interesting to note, female OBGYNs are less likely to practice in rural areas than male OBGYNs, but OBGYN has the highest proportion of underrepresented minorities of all other specialties, and underrepresented minority OBGYNs are more likely than white or Asian OBGYNs to practice in federally funded underserved areas or high poverty areas. Finally, on this slide, the cost of professional liability insurance has the greatest financial impact on an OBGYN practice. Over 80% of OBGYNs surveyed report rising medical liability insurance costs as a serious concern, and nearly two-thirds of OBGYNs over 50 report retiring early, at least in part due to rising medical premiums. Finally, women's health delivery is moving towards team-based care. The OBGYN workforce must take into account alternatives to accommodate increasing numbers of patients and improve effectiveness in delivering health care. A shift to more collaborative, team-based care will improve access to health services while maintaining quality satisfaction. Qualified healthcare professionals working in concert with physicians will help meet this unmet need while reducing the cost of care. ACOG enthusiastically supports collaborative team practice and team-based care, including models such as patient-centered medical homes. ACOG supports models that use every member of the team to the full capacity of their training and skills, as our colleagues at Nurse-Midwives mentioned. Additionally, team-based care meets the Institute of Medicine's expectations of healthcare and the Institute for Healthcare's triple aims of improving the experience of individuals and families, improving the health of populations, and lowering per capita costs. Currently, more than half of all OBGYNs employ non-physician healthcare professionals, including nurse practitioners, nurse midwives, certified midwives, and physician assistants. While health reform is not the looming threat it has been since the start of this year, 2017, at ACOG we remain cautious about the future and the ongoing reform efforts in Congress. Talk a little bit about what it was like pre-ACA. Before the Affordable Care Act, 13% of all pregnant women were uninsured. Health coverage for about 39.5 million insured women was subject to lifetime coverage limits, causing many to lose coverage mid-treatment or mid-pregnancy. Nearly a third of pregnant women lacked health insurance or was forced to move between different types of coverage around the time of pregnancy. Only 12% of policies on the individual market covered maternity care at all, and 1 in 5 women of childbearing age was uninsured. Additionally, insurance companies could impose waiting periods for up to a year, but often conveniently at the 9-month mark before they would allow a woman to use maternity care coverage. And due to gender rating, a 25-year-old could find herself paying over 80% more than a man for identical coverage. While not perfect, the ACA has provided women with landmark health gains. 8.7 million women gained maternity services under the ACA. Over 55 million women gained access to preventative services with full coverage and no cost sharing. The prohibition on pre-existing conditions ensured that 65 million women with conditions, including a C-section or a history of domestic violence, could not be denied coverage. And the prohibition on gender rating saved approximately $1 billion in annual costs. The ACA also ensured direct access to OBGYN care, which prior to the ACA, I believe was only in 22 states and was a state by state. So how do we address these challenges on the state and federal level? An efficient, high-quality women's health care system depends on the right number of physicians and other health care providers in the right locations at the right time. State and local efforts should include Medicaid expansion to ensure continuous coverage for low-income women. There is concern that with numbers of Medicaid waivers, we're going to see a decrease in the number of newly insured women. Additionally, the addition of a rural training track in medical residency programs. Currently, 24 family medicine residency programs have incorporated a rural training track. Graduates of these programs are 2 to 3 times more likely to practice in rural areas than graduates of family medicine residencies overall. The majority of those physicians initially selecting rural sites tend to remain in rural locations for up to 2 years or more after graduation. Next bullet is the implementation of team-based care models, as we've discussed, to achieve quality, efficiency, and value in the evolving healthcare system. Organizations across all specialties should develop team-based care. Team-based care can respond to emerging demands and reduce undue burdens on practitioners. Uniform licensure standards across all states. State licensure and scope of practice laws, as Dr. Lowe mentioned also, should support common minimum education training and accreditation standards. In order to improve provider collaboration and systems integration, licensure laws should ensure a level of consistency in the credentialing of practitioners who provide health services and should also recognize that the skills, training, clinical experience, and demonstrated competencies of physicians, nurses, physician assistants, midwives, and other healthcare professionals are not interchangeable. Accreditation, education, and professional certification should be a precondition of licensure in all states. And finally, the development of an integrated maternity care system. ACOG calls for system-level improvements in maternity care, including implementation of a new uniform classification system for how risk-appropriate maternal care is delivered across the U.S. and new regional criteria for facilities. And again, as Dr. Lowe mentioned, we are happy to be working with many provider partners, including the American College of Nurse-Midwives in some of these developments. On the federal level, ACOG focuses on possible policy solutions that address 4 primary areas: increased residency slots for obstetrics and gynecology, medical liability reform, data collection in areas of greatest need, and ensuring that residents are placed in health professional shortage areas. Increasing funding for graduate medical education is essential to address the projected physician shortfall. An increase in the number of residency slots for obstetrics and gynecology funded by Medicare would help accommodate additional medical school graduates. Without sufficient funding, some residency programs may decrease the number of residency positions they're willing to hold. There are a couple bills right now. The Teaching Center Reauthorization Bill, the Teaching Health Center Graduate Medical Education Extension Act of 2017 reauthorizes the Teaching Health Center program. Teaching health centers train physicians in community-based primary care settings, such as federally qualified health centers, and primarily serves underserved patients. This legislation was just reintroduced in the House and Senate this summer, and it would reauthorize the Teaching Health Center Graduate Medical Education program for 3 years. It would also allow for the expansion of new programs within current health centers and the creation of new centers to meet the growing need for community health services. There is another bill, the Training Tomorrow's Doctors Today Act. It has not yet been reintroduced in 2017, but this legislation would fund 15,000 additional residency positions through Medicare, and we continue to advocate for it. Under medical liability reform, as I mentioned, raising premiums contribute to early retirement among OBGYNs. There are many number of currently introduced medical liability reform bills that ACOG supports in the current Congress. I'll mention just a few right now. The Protecting Access to Care Act passed the House earlier this year and would institute a number of reforms, including a $250,000 cap on non-economic damages. The Access Act, or the Accessible Care by Curbing Excessive Lawsuits Act, would encourage speedy claim resolution for both patients and physicians to ensure they aren't wrapped up in lawsuits for more than 3 years. And the Good Samaritan Health Professionals Act, which would allow physicians to practice across state lines or licensure to transfer across state lines in the case of national disasters. For our next two bullets, data collection and health professional shortage areas, before we take a look at the legislative solution, I'm going to quickly discuss health professional shortage areas. HRSA develops shortage designation criteria to determine whether a geographic area, population group, or facility is a health professional shortage area, or a HPSA. The National Health Service Corps was created in 1972 to help fill provider shortages, and does this by providing scholarships and loan repayments in exchange for service. Those providers are placed in health professional shortage areas. Currently, over 50,000 providers, including OBGYNs, have participated, and over almost 11,000 providers serve more than 11 million Americans at over 5,000 sites. As it stands today, there are shortage area designations for primary care, dental care, and mental health care, but not for maternity care. The midwives and OBGYNs that currently participate in the program OBGYNs qualify as primary care providers. As more than 6 in 10 patients who access care through a women's health center do consider the women's health provider their main source of care. However, as we'll see in the next slides, there are unique benefits to having maternity care a specific designation. The Improving Access to Maternity Care Act. Currently, OBGYNs in the National Health Service Corps are sent to sites that may not have high maternity care needs and we do not know because there's no specific data collected to help identify maternity care specific shortages and identify areas with these needs. This legislation would require HRSA to designate maternity health professional shortage areas based on population needs, and it would target maternity care resources where they're most needed, helping to ensure healthier pregnancies and healthier babies. The National Health Service Corps has a really strong retention rate, which will help ensure access to health care in underserved areas over time. Of ACOG fellows, approximately half will practice in the same state they trained, and 2/3 will practice in the state they attended medical school or undertook residency. Meanwhile, in the National Health Service Corps, they found that 82% of National Health Service Corps clinicians continue to practice in underserved communities in the short term. That's up to 1 year post-completion. And almost 60% of these clinicians will continue to practice in underserved areas 10 years later. Which is a really strong retention rate. The Improving Access to Maternity Care Act was first introduced in 2014. A hearing was held in December 2015, and the bill passed last fall, November 2016. When it was reintroduced in January of this year, it was advanced really quickly, and we now are calling on the Senate to support this legislation and move it forward. ACOG and ACNM worked closely on this legislation and continue to. From a joint press release on the passing of this bill in January of this year, this legislation addresses ACOG and ACNM's long-standing priority to ensure every woman has safe and timely access to care from a women's health care provider, and seeks to determine areas throughout the country that are experiencing a significant shortage of full-scope maternity care professionals, including OBGYNs, certified nurse midwives, and certified midwives. ACNM and ACOG continue to work on this legislation. ACOG has a petition available on our website. I didn't put it here, but it's acog.org/action or acog.org/action that does say as an OBGYN, but it is editable, so we encourage anyone to check it out and contact your senators and help us advance this legislation. Thank you so much.
Thank you so much, Mallory. Our next speaker is Katy Kozhimannil, Director of Research at the Rural Health Resource Center and an Associate Professor in the Division of Health Policy and Management at the University of Minnesota School of Public Health. And we're so grateful she's here with us today to share her research and her incredible expertise on the rural obstetric workforce, as well as federal and state policy opportunities. Katy?
Hi, everyone. I'm so pleased to be with you this afternoon. I have a chance to follow my fantastic, tell you a little bit about the research that we have done looking at what folks in rural communities experience with respect to maternity care and the workforce. So I want to start off by acknowledging my amazing group of collaborators and our wonderful federal funders. This work that I'm going to present today is a quick consolidation of research that's a range of different projects that we've done looking at maternity care, access and quality, and workforce in rural areas that's funded by the Federal Office of Rural Health Policy at HRSA. And I also want to acknowledge my colleagues at the Rural Health Research Center at the University of Minnesota and our advisory group. We have had a fantastic obstetric care advisory group that consists predominantly of obstetric nurse leaders in rural hospitals across the country. And we've learned so much of our work is informed by the experiences of women, families, communities, and those that are on the ground and doing the work on a day-to-day basis. So I really want to acknowledge with gratitude everything that they've contributed. So I'm going to move forward. I'm going to provide a very brief bit of background context, and then what I want to do is present some kind of high-level research findings. It's a little different than what we've heard so far on this webinar, but I want to bring to bear the data that we have uncovered in our work in looking at who is providing maternity care in rural communities. So we've heard a lot about childbirth generally being both the most common and most costly reason for hospitalization in the U.S. About 500,000 babies are born in the rural USA every year. So there are a lot of people that need maternity services in rural communities. About half of all births are covered by Medicaid across the United States, and that percentage is higher in rural hospitals compared with in urban hospitals. And it's all of the discussion that we're having today around maternity care access is happening in the context of declining access to obstetric services in rural communities. And this follows on. I'm not going to focus on this today unless there are questions that come up around it, but our group has recently published a couple of policy briefs that have highlighted the reduction in access to hospital-based obstetric services in rural counties across the U.S. So between 2004 and 2014, 179 rural counties lost access to hospital-based obstetric services. And that meant by 2014, more than half of rural counties had no obstetric services. We also found that closures were more common in more remote, less populated rural communities in only about 40% of non-core rural counties. So that's the way that we measure this. We've got metropolitan counties, which are urban areas, micropolitan, which are counties that have small towns, and non-core, which are rural counties that do not have sort of even a micropolitan-sized town. So we also found when we looked at this is a lot of variability across states. And one thing I just wanted to highlight here is that some states have a wider swath of rural counties that do not have access to obstetric services, and I'm using the term obstetric here. I recognize that language matters, and I guess I want to correct myself and say maternity care, and talk about maternity care more broadly. So, heading here are the states that have very high percentages of their counties without any hospital-based maternity services. So there are many places where there's declining access to services, but in the rural hospitals that do provide maternity care, who is providing those services? We set out to answer that in our research, which I will describe, and we looked at, what types and combinations of clinicians are delivering babies in rural hospitals. What's the relationship between hospital birth volume, the number of births that are happening at each hospital, and the staffing models at those hospitals? And what are the staffing challenges that rural hospitals are facing? To answer these questions, he used data from the Federal Healthcare Cost and Utilization Project. The statewide inpatient databases are a census of all hospital discharges in, you'll see the 9 states that are highlighted in yellow, hospital discharges. And we studied all the hospital births to rural residents in these 9 states. In addition, because information on who's providing care is really difficult to come by, we conducted a telephone survey of all 306 rural hospitals in these 9 states that had at least 10 births in 2010. And we called up these hospitals between November of 2013 and March of 2014. We had a response rate of 86%, so we heard from 263 of those hospitals, and most of the results that I'm going to present today derive from the answers that we got from calling up the obstetric nurse managers predominantly in these hospital settings. So I'm going to gloss over methods pretty quickly, but if anyone is really interested in understanding the numbers and how we got to them and the methodology or analytic tools that we used, I'm happy to talk more about it. We divided rural hospitals into quartiles by annual birth volume, looking at low-volume hospitals, those with between 10 and 110 births a year, medium volume between 111 and 240, medium high, which is 241 to 460, or high birth volume, which is more than 460 births a year. Now, to some of you, that may seem like what we're calling high birth volume may seem like low birth volume in a lot of urban settings. I think that's true, but I want to take some time to think about that because the rural setting is very different. It has important implications for what hospitals can afford in terms of staffing and employment, as well as private practice models and how they're able to sustain themselves financially or not. So we conducted multivariable regression analysis, and we also did qualitative analysis of the open-ended questions that we asked about workforce changes and staffing challenges in rural hospitals. So I'm going to show you a few of our results. So this slide shows just the average number of obstetricians or family physicians that were in surveyed rural hospitals that were attending births in these hospitals by birth volume. So on the left, you have among all rural hospitals, you have an average of just over 3 of I don't even think we can see, so just over 3 obstetricians. I'm not sure if you all can see the reddish bar is obstetricians, and family physicians are in blue. Ooh, that is there. Okay, great. Double checking my slides while I present. And just over 4 on average that are delivering babies, family physicians in rural hospitals. But you can see that pattern differs dramatically by birth volume, with kind of an increasing number of obstetricians attending deliveries with birth volume, and a different pattern for family physicians. First of all, I want to note that especially in the lower volume settings, there are family physicians, there are more family physicians that are providing maternity care services than there are obstetricians. So certainly when we're having discussions around the maternity workforce in rural areas, family physicians are absolutely an integral part of that discussion. And I think that this slide makes that very clear. Next, I am going to look at the see if that's coming up. There we go. The percentage of obstetricians and family physicians that are employed by the rural hospitals that we talked with. So you have folks that are in private practice versus those that are employed by the hospitals, and the hospitals have different strategies of attracting and retaining maternity care clinicians. So what you see here is that obstetricians are on the left side of the vertical line here. Almost 60% of all obstetricians that attend births in rural hospitals in the United States are employed by the hospital, and that's about 40% for family physicians. And you can also see a different pattern over time with a higher percentage of clinicians, both obstetricians and family physicians, but especially obstetricians, employed in lower birth volume settings compared with higher birth volume settings. And that relates to the financial feasibility of private practice models versus the need for a hospital to actually employ and guarantee that salary and revenue for their providers. Next, I'm going to turn to a discussion of the nursing workforce. So I have one slide here on these results. We have a whole paper on this topic, and would encourage those of you that are interested in this topic to take a look at that. But one of the top challenges, and we'll get there in a moment, that we heard from rural hospitals was it was not just about attracting maternity care clinicians in the form of physicians, obstetricians, family physicians, or midwives, but really around high qualified recruiting and retraining a highly qualified nursing workforce as well. One of the major differences we saw by birth volume was whether rural hospitals reported having dedicated nurses that worked only in labor and delivery in the postpartum unit, or whether they were shared across different service lines in the hospital. And that was really strongly determined by birth volume, with hospitals with fewer than 300 births. Almost 80% of those hospitals had shared nurse staffing across units. And next, I'm going to provide a few results as they relate to the practice of midwifery in rural hospitals. In this survey, we asked about whether midwives attend births at hospitals, and we found that CNMs attend deliveries in about a third of rural maternity hospitals in the states that we studied. And there was a lot of variability across states, which may relate to state scope of practice laws, which we've already discussed. In rural hospitals that provide maternity services, CNMs practiced alongside obstetricians in 86% of those hospitals, and they practiced alongside family physicians in 44% of the hospitals, again highlighting the important role of family physicians in rural maternity care. We also found that larger volume rural hospitals were more likely to have CNMs attending births compared with lower volume rural hospitals. And when we talked to rural hospitals about their plans for the future, many, more than half, said that their future plans included trying to recruit midwives to practice maternity care at their hospital. And that was a very aspirational statement. And obviously, as we know, recruitment and retention are challenging, but that's a big issue on the minds of rural hospitals that are hoping to meet their maternity care needs. So when we talk about what rural hospital obstetric unit managers mentioned as particular staffing challenges, there were a number of issues that came up. Scheduling was the most frequently mentioned challenge, especially when you have low birth volume or variable birth volume. It's very difficult to consistently staff a unit. These scheduling challenges were also related to work-life balance issues and how frequently providers needed to take call, as well as challenges with respect to sharing nurse staffing across different units of the hospital. Training and making sure that people were able to keep up their skills was mentioned by 23% of hospitals. Recruitment and retention by 20%, just over 20%. Census fluctuation, so this idea of birth volume, moving up and down and needing to have resources immediately available when there is a birth, and the unpredictability of birth was mentioned by almost 20% of the hospitals. And intra-hospital relationships was mentioned as a staffing challenge, again, relating to shared nursing staffing and also to the use of scarce resources in rural hospital settings. Obstetrics was frequently cited as And so one of the most commonly cited reasons for closures of obstetric units is that service line is not as financially lucrative as others. And when there's a battle for resources, often the service lines that generate the least revenue lose out with respect to gaining access to additional resources for staff recruitment, retention, training, some of these other challenges that we see listed here. So that's a part of this story as well. So in summary, we found that rural hospitals with lower birth volume were more likely to have family physicians and also general surgeons, which I didn't mention here, but are also an important part of the maternity care workforce in especially small volume rural hospitals. We found hospitals with higher birth volume more frequently having obstetricians and midwives attending deliveries. We found that employment of physicians decreases as birth volume increases in rural areas, and that 3/4 of rural hospitals with fewer than 300 births a year have shared nurse staffing. Midwives are an important part of the rural maternity workforce, attending deliveries in 1/3 of rural hospitals. And the workforce challenges that were reported by surveyed hospitals tended to relate very strongly to their rural or remote location and to low and variable birth volume. I'm going to turn now to a very brief discussion of some of the things that we can consider in the way forward with respect to national policy and state policy. And I'm not going to spend a lot of time here because we've already heard a really in-depth discussion on the Improving Access to Maternity Care Act. I just want to emphasize in the context of rural maternity care how important the health professional shortage areas designation has been for rural workforce shortages generally, and how specifically important this could be in rural settings to designate maternity care shortage areas. At the state and local level, there are a lot of different things that can be done. We've heard about state scope of practice laws. I want to re-emphasize Medicaid policy, which are broadly determined at the state level. Again, Medicaid funds half of all births in the U.S., and so the policies that it sets with respect to coverage, benefits, reimbursement rates, payment policies, and managed care arrangements they play a strong role in access to maternity care and in the maternity care workforce. All of this is in a little bit of flux right now as we see from the federal level a greater push toward more state autonomy, more state flexibility in how they implement their Medicaid programs, and so this is going to be something to keep a close eye on in the years ahead. And just a brief mention of other state and local efforts. I know we have a lot of folks on the line today from states, and there have been a number of, I can't emphasize enough how important the state level policies are in really shaping who can provide maternity care, who is providing maternity care in rural areas. And there are efforts toward homegrown rural workforce, so training folks from rural areas, ensuring that there are professional schools in rural areas or rural tracks to training programs, encouragement of rotations that include obstetrics and maternity care in rural areas, including in family medicine, and subsidies for continuing medical education, another ongoing training capacity. We've discussed this briefly, but CMEs and other ongoing training opportunities, including interprofessional training opportunities in rural settings, is extremely important given how much you see interprofessional collaboration in terms of practice of maternity care in rural areas. State and institution level quality improvement initiatives and collaboratives can help to leverage resources across different small volume settings. So in rural communities, you often don't compete with the nearest other hospital providing maternity services because it's likely to be quite a distance away. And because of there's sort of not competition because of geography, there's a greater incentive to potentially collaborate and share resources. For example, getting a simulation van that goes across a region. I know there's a collaborative of small rural hospitals in Wisconsin that does this. They pool their resources to have a mobile simulation unit to train their staff on how to respond to obstetric care emergencies. So we have to look for opportunities for ways to address some of the staffing challenges that rural hospitals have noted. And that's everything that I have for you today. I've put up a few links here for additional information, if any of those would be helpful to you. And I thank you for your time and attention today and welcome any additional questions.
Thank you so much, Katy. We've heard a lot about workforce challenges and policy solutions today, and we wanted to close with an example of how an innovative collaboration in Minnesota between providers, the health plan, and community partners is helping to connect women to prenatal care. And I'm pleased to now introduce Ashlyn Christianson, Public Health Manager of Government Market Solutions for Blue Cross Blue Shield of Minnesota.
Hello, and thank you for your interest in learning more about our high-risk pregnancy pilot. My name is Ashlyn Christianson, and I currently manage the day-to-day of the pilot. What prompted Blue Cross to become interested in a maternity care pilot? As a payer, Blue Cross historically has not had the feet-on-the-street expertise that other local agencies have. We rely on the data that comes from claims to understand the health of our insured population. And as you're probably aware, sometimes claims are not coded correctly. Claims are sometimes submitted months after the appointment occurred, and not everyone who is insured gets preventative care or seeks out medical care to control a medical condition. Additionally, limited information that we glean from claims data causes us to fill in the blanks. It does not provide us with understanding the whole person, and it leaves us at a disadvantage to understanding true population health. Our current maternity management program is a telephonic opt-in program. Women who are pregnant can call in to speak with a case manager who can give them information about a healthy pregnancy. We are limited with this telephonic program because the case managers do not leave the building. They do not have the community relationships to refer pregnant women throughout the state, nor may they understand the external barriers that the pregnant women may have when trying to access care, such as available transportation in that community. We decided to be bold, and we decided to innovate. The idea for this pilot came from external Blue Cross relationships and the understanding that we have to meet the members where they are. After traveling to about 4/5 of the counties in Minnesota and speaking with public health agencies, I heard that public health overwhelmingly identifies pregnant women as early as 8 weeks into pregnancy through WIC clinic referrals. At Blue Cross, we are lucky to find out if a member is pregnant between their 4th and 7th month, if the provider bills us in a timely manner, and if the member gets any prenatal care at all. So I went to Ramsey County Public Health, which is St. Paul, Minnesota, our largest membership population at the time, and I asked how the referral process went for them. At that time, half of the pregnant women in WIC accepted a referral to public health, but only half of those referred actually followed up with public health. So Blue Cross wanted to help individuals make connections with the agencies who could assist them with better birth outcomes. We knew that Ramsey County has the best evidence-based home visiting program in the state, and we wanted to partner with them to increase referrals and to get better pregnancy outcomes for our members. To do so, with public health and WIC's blessing, we wanted to support the hire of a community health worker, or CHW, place the community health worker within the 7 WIC clinics in Ramsey County, and have the community health worker identify pregnant women on the spot to immediately engage with them and to have warm handoffs between agencies and community support systems. Our hope was that once the position of the community health worker was established, it would become reimbursable through claims, sustainable, and replicable across all counties in Minnesota. Here is the example of what we set the community health worker up to do. The role of the community health worker is to be able to assess needs, connect mothers and their families with needed resources, refer and provide warm handoffs to other community agencies, and provide education as appropriate to the mothers about their pregnancy. Because we're a little short on time, I won't go into too much detail on this graphic, but it does show the journey and how the community health worker is able to insert herself throughout, in this example, the woman's name is Nicole, how the community health worker can insert herself into Nicole's pregnancy journey and assist with any needs that Nicole may have or any barriers that she has that takes her away from focusing on her pregnancy. Here's a model that shows how the community health worker is in the center of care. First, finding the individual at a WIC clinic, but then following up with the individual at the location of their choice. The community health worker also does warm handoffs and referrals to community organizations, and depending on the risk assessment, refers the individual to public health, to the telephonic maternity management services, or to other community programs. Some lessons learned so far. We are about 4 months into the pilot, and let me tell you, we have learned so many things. With the community health worker, we insisted that the community health worker not be a Blue Cross employee. We gave startup funding for this pilot to a provider agency called Livio. Livio is a mobile clinic that goes to where the people are to provide services. The CHW is now an employee of Livio and has access and connections to physicians, social workers, and a nurse midwife. Community health workers are an emerging profession. Many are inexperienced, or their experience that they do have is very limited in scope. The community health worker program is approximately 14 credits. It takes a minimum of 120 days for the Department of Human Services here in Minnesota to credential a community health worker. So during the waiting period, the community health worker is unable to get reimbursed. So upfront funding support is needed for any new community health worker graduate. Additionally, one of the lessons learned for the community health worker is that it has taken an incredible amount of resource-intensive oversight. When it comes to care planning, reimbursable hours, training, professional development, motivational interviewing, ethics and barriers, computer programs. So for example, the community health worker that we initially hired was fresh out of school, had no healthcare background, and wasn't sure how to use an Excel form, a document. So we had to do a lot of education and training to make sure that documentation was accurate and that we could use that data later on. Some of the lessons that we learned partnering with WIC. Because there are 7 WIC clinics in Ramsey County, there's not enough traffic at this time to justify 7 individual community health workers. We're starting with 1 community health worker and placed her on a rotation at the most high-traffic WIC clinics. We put iPad kiosks at the other locations with simple intake questions that asked about social determinants of health. We found that when calling or texting the moms for follow-up, they were more likely to engage with the community health worker if the community health worker had a resource or solution for their housing, food, or other needs. I have to say that WIC has been a fantastic partner. They're allowing an outside agency to take up space in their very small clinics, and they have been willing to use their very limited staff to inform pregnant women of the pilot and the opportunity to connect with a community health worker. The Wi-Fi in the WIC clinics is unreliable for our iPad kiosks to work consistently, so that has been a barrier to downloading and collecting information that the women input in the kiosks. Probably the most major takeaway is the WIC staff buy-in is the most important, because they need to trust this new community health worker who's invading their space so that they're confident in referring the pregnant women to either the community health worker or the iPad. So we've been sharing our success stories with WIC, and that seems to motivate them, knowing that women are being taken care of. WIC does not care about insurance coverage for their individual women. Their focus is on nutrition education, and they believe that if someone is willing to jump through hoops to get to WIC, they need the assistance and will provide the education. Insurance coverage has nothing to do with WIC services, so WIC is considered a safe place for individuals because WIC does not ask intrusive or prodding questions. Women feel comfortable going to WIC and they spread the word. I think that's why WIC has been such a high traffic area for this population. Our lessons learned with public health. At Public Health's request, we have decided to open up training for all public health staff and WIC clinic staff to attend IDI trainings, which stands for Intercultural Development Inventory. It is important for Blue Cross that our partners have cultural competency awareness training as they meet with our members, and as the demographics of Ramsey County and the state of Minnesota have significantly changed, we believe that having this cultural competency will lead to better engagement and better health outcomes for mom and baby. Livio, the mobile clinic. Livio is a startup, so getting the kinks worked out of a brand new provider can also be a challenge within a pilot. Technology setup took more time than anticipated, and language translation for our kiosks was a little delayed. Lessons learned, and Livio needs the ability to text clients. Mail and phone calls are not generally successful when reaching out to individuals, but text messages offer more success. Pregnant women. Most, about 50 to 70% of the women who are going into WIC have no insurance coverage. So the claims numbers we based our pilot metrics on show that the bulk of our membership begins when a woman delivers and not before, meaning that without women who are consistently covered by insurance throughout the 9 months prior to delivery, there's no way for Blue Cross to find or assist these moms in getting appropriate prenatal care. For these women who show up at the WIC clinics and do not have insurance, the community health worker refers them to an agency called Portico HealthNet. Portico HealthNet has certified MNsure navigators, which can assist the individual at no cost in choosing a health plan that works best for her. Additionally, most Medicaid members don't know who they have insurance through. They know that they have insurance, but they are unsure of who the coverage is with. Many do not actively select a health plan, and the health plan is chosen for them as the default in each county. This means that many of the women that the community health worker is interacting with do not even know what benefits Blue Cross offers them, even after all of the informational mail we send out to the members as required by the state, or the mailings that we send out as education for the members. There's a low level of literacy. One woman that met with a community health worker did not know that she was getting a McKenna shot to reduce her chance of a subsequent preterm baby. She just knew that she was getting a weekly shot from her doctor. Finally, trust. Pregnant women often ask the community health worker if she is a social worker. This leads us to believe that they have not had great experiences in the past with social workers and are willing to work with the community health worker because she is not one. Some potential barriers that I have noticed while working on this pilot. Churn impacts the continuity of care. If a member has Blue Plus in May, but falls off eligibility in June, and then chooses or defaults to another health plan for insurance coverage in July, there are so many potential impacts to the outcome of that individual's health. Perhaps the doctor that is in the Blue Cross network is not in the competitor's network, or the individual who goes without insurance is unable to seek prenatal care, or the provider who is seeing the individual is not able to bill for a global payment package because the individual did not have consistent health plan coverage for all of the prenatal visits, which leads us to the DHS rules. DHS forbids health plans from reminding members by text message that their coverage is about to lapse. This creates gaps in care and can create higher costs for everyone. Additionally, health plans have been explicitly told that we are not to collaborate with the counties to get pregnant members into the appropriate risk rate cell for pregnancy. Instead, the Department of Human Services wants the health plan to inform our DHS contract manager of the pregnant woman. Then DHS will tell their operations department. Then the operations at DHS will mail out a letter to the individual asking the individual to contact their financial worker. I think you understand the complexity and delay in coverage this causes for the individual. If any of you have worked with the Medicaid population or any population that receives mail for that matter, you understand that most of the paper mail sent out goes straight into the trash. Medicaid members also include a population of mobile and homeless individuals who may not have a current mailing address on file. When a member is in the appropriate rate cell, the door opens for the member to have zero copays, and they are given additional prenatal benefits. This is a huge loss for pregnant women who may not be able to afford expensive prenatal vitamins if they are not in the correct rate cell. and those women who go to the emergency room for care instead of seeing a regular and consistent provider. This is also a huge loss for health plans and the public because without appropriate access to care or access to medications and vitamins, healthcare costs can go up for everyone. On to clinic policies. Many clinics have a policy not to see a pregnant woman until 9 weeks, and even then the pregnant woman doesn't get to see her healthcare provider. At 9 weeks, the clinic just does an intake. It is at 12 weeks that they are able to see their provider. For this pilot, if the community health worker identifies a pregnant woman before 12 weeks, we found that it was best for the community health worker to refer to an FQHC, which are federally qualified health centers. FQHCs have an open-door policy. There's no minimum pregnancy requirements to see pregnant women, and they always keep last-minute appointment times on their schedules to get individuals in the same day, which is a huge win when working with an engaged member who is willing to get prenatal care set up that same day. Additionally, one of the Ramsey County WIC clinic locations is in the same building as La Clinica, one of the FQHCs, so warm handoffs are especially smooth at this location. Already into the pilot, we have stories of success. Capacity building between participating agencies. WIC can now focus on nutrition education. The community health worker focuses on all of the other social determinants and pregnancy education. Livio now has more clients and increased staffing capacity. They've added some community health workers to work on tackling other issues for members. Public health has increased referrals into their evidence-based home visiting programs, Nurse-Family Partnership, Healthy Families America, etc. Blue Cross, we now have healthier, happier members. We're looking forward to lower costs of low birth weight babies, preemies, and NICU. Additionally, individuals' needs and social determinants of health are being met. One of our success stories is of a family who met with a community health worker and learned that Blue Cross offers free transportation to medical appointments. The husband began to cry as they only had one vehicle in the family, and he was caught between taking his pregnant wife to medical appointments or going to work. Now his wife would have access to transportation through Blue Cross, and he could keep his job. Members also report providers do not have time to answer questions and concerns while they're in their office. So the community health worker is a huge help for the individual in clarifying what occurred during an appointment and to get the individual's questions answered. One more success story. A woman had sickle cell and did not get along with her financial worker, so no one at the county was aware. She disclosed her medical condition to the community health worker after a couple of interactions and was able to get additional support and education about her condition. I have a list here of some thoughts about expanding to the rest of Minnesota, but the main takeaway is that one size does not fit all. For every county in Minnesota, there are so many nuances. I know this was brief and a high-level overview, but I hope that it was enough for you to get thinking about bold and innovative pilots and programs also. Please feel free to contact me if you think of any questions after this webinar.
Great. Thank you so much, Ashlyn. Thank you to all of our speakers and to our audience for sending in lots of great questions. We had a lot of questions about the role of family physicians, and it was touched on in various presentations, but would love for the speakers to comment on how we can, foster more collaboration among maternity care providers, especially those that we talked about today, in working with family physicians, especially in these rural areas where we're facing shortages of OBs and other providers. Lisa, do you want to start?
Well, I think one of the things that when we've talked about shared educational pathways, the opportunity for more family medicine physicians in training who are interested in OB to participate in some of these specifically rural-targeted training programs. And also we need to think about expanding our IPE experiences like the ACOG and ACNM initiative to also include family medicine providers who want to continue to also develop OB care practices.
Would anyone else like to comment on the role of family physicians?
This is Katy, Kozhimannil. I'm happy to jump in just to say we've been doing research on maternity care for quite some time, and I have a prior study that showed that about a third of all pregnant women reported care from a family physician in the prior year. That's just across the board, and there's some really wide regional variability here. But I think that the role of the family physicians play in care for people during pregnancy, around the time of childbirth, and also in integrating care as they transition in and out of pregnancy-related services is just really important. Well, I echo Lisa's really thoughtful comments around interprofessional education, the involvement of family physicians.
Another point I would also make is that in the same way that nurse midwives and certified midwives have challenges gaining clinical privileges for obstetric care, family physicians often face some of those same challenges. And while we don't have time to really go into a lot of detail, looking at how hospitals are providing clinical privileging to allow for obstetric care services to be provided is another barrier that we haven't really had much opportunity to touch on today, but is another area for focus.
Great, thank you. Ashlyn touched on, their collaboration with local public health departments. Can any of the other speakers talk to what roles you see for local public health departments as partners in addressing workforce shortages?
This is Katy. I can respond to that very briefly to say that in rural communities, there are fewer touch points for pregnant individuals with different social and support systems. The local public health is integral and to providing responding for some of the social needs and psychosocial needs that pregnant individuals and their families face, and partnering with the healthcare delivery systems in providing the medical care that they need. And so it's a very natural fit and collaborative process, especially in rural communities where the number of people that are involved in this is small and people know one another and they run into each other. That's a real strength of rural communities. It's that integration is very natural.
I would echo that and say that if we think about optimal ways to build an integrated system of maternity care, one of them is to have integrated infrastructure to provide that care, and that's clearly where the public health system can support that so that individuals can have that ready access touch point, as Katy noted, rather than distributing or creating more challenges in accessing the right provider at the right time.
Great, thank you. Another question we had for Ashlyn, could you talk about why you chose to use community health workers versus other professionals? And also, could any of the other speakers just expand on the use of community health workers and supporting their integration in the healthcare system going forward?
Yes, so we decided to use a community health worker because ideally the community health worker comes from the community. They have lived the same situation of the individual that they're working with. They speak the language, they know the culture, and they also have a pulse on the resources that are available in the community. So with this partnership with Livio, now that they've hired on additional community health workers, it sounds like they are sharing resources amongst each other in their different respective, if there's a better resource for Hispanic community or a better resource for Somali or Korean, they're able to discuss that amongst each other.
I would also add that when we think about where a lot of the risk factors and contributors to some of the health disparities and health outcomes that we see, the opportunity to really engage with community members in a respectful and deliberate way that honors where they are in the community is really facilitated through community health workers, and that part of when I referred to the larger infrastructure that's available to provide touch points with maternity care providers, it's not always the direct medical provider that's the primary resource for some of the aspects of reducing risk, and some of the successful models that have been really developed have demonstrated the value of the social support, including the role of doulas, community health workers, looking at alternative models where you're bringing together community in the form of centering group prenatal care programs are all excellent ways that we can sort of turn the way that we deliver care on its head and really put more resources in the community and less emphasis on time having to be spent physically in a building waiting for a provider to be seen. So there's new opportunities to be innovative in the way that we approach care, and particularly in maternity care.
Great, thank you. I know we're getting past our time. There's a few more questions that came in that we're going to share with the speakers, and they've graciously agreed to get back to folks directly with some of these additional questions. And we do want to be cognizant of our speakers' time and thank them for joining our panel today. I really appreciate all of their expertise. I'd also like to thank AMCHIP for their support in bringing this webinar to you today. We would like to ask you to provide feedback by using the survey button on the bottom of your screen. And thank you all again for joining us today. We will make a recording of the event available, and the slides are also available on our website. Thank you all again.